All right, so title slide here, chronic headaches. Kind of came up with the title a few months ago prior to really digging into the data, but I wanted to stick with how we phrased it and how we marketed it. You'll see as we go through that TBI and obstructive sleep apnea exist on spectrums from mild to severe. And so a lot of this information kind of pertains across the board. But the vast majority of TBIs that we generally see in work comp, especially ones with delayed recovery and persistent neurocognitive symptoms, tend to be of the mild variety. And that's where we kind of end up scratching our heads. So chronic headaches potentially for us as well as for the patient as well, while we're trying to sort out, are these sequelae from the injury or is there something else going on? I'm clicking next, but it seems frozen. Let me try this again. There we go. All right, so some of these slides are a little busy. Part of that is just there's so much information with both sleep apnea and TBI. And part of it too is we're going to have this posted on our website. And so it could be something that you could reference later and pause and look at stuff. It's just easy to fill up a PowerPoint slide pretty quick when you're trying to put all the important information in. So these are a couple cases. Big picture, we're talking about a concussion or TBI, and essentially those are the same thing. In the context of work, the person has risk factors for sleep apnea and is slow to recover with persistent neurocognitive symptoms. So Mrs. MVA, or motor vehicle accident, this is a 52-year-old female who was in a crash. She had no loss of consciousness, but she did have a pelvic fracture, so it was a legitimate car crash. Past medical history is significant for obesity, fibromyalgia, depression. She reported mild OSA on a sleep study 15 years prior, but had not had treatment. Her BMI around the time of the injury is around 38. She's got elevated blood pressure. She was hospitalized with slow recovery related to the pelvic fracture. And then her headaches and neurocognitive symptoms seemed to develop weeks to months after the MVA. The neuropsych eval 1 year after the car accident. Persistent symptoms, likely not TBI related, concern for sleep dysfunction. From what I could tell in the record I was reviewing, it didn't look like that sleep study had happened, but the IME occurs about 2 years out from the injury. And she continues to suffer from the neurocognitive issues, headache, fatigue. She's napping a few times a day. And then she's also probably got a medication overuse syndrome of some sort, because she's routinely using Tylenol and hydrocodone essentially every day. So she's got a lot of risk factors. And then we'll move on to Mr. Concussion, 35-year-old male firefighter EMT. It sounds like he was reaching into a vehicle to turn it off when the airbag deployed. It basically impacted him. He was dazed but had no loss of consciousness, but complained of depression, memory issues, brain fog, forgetfulness at his IME 1 year post-accident. He is obese with a BMI of 36, and he also had elevated blood pressure, 152/103. A neuropsych eval was done, and there was concern for OSA due to high score on the Epworth sleep scale, nighttime snoring, daytime fatigue. It was unclear from the report if a sleep study had ever been done. So these are just kind of two examples. There were many more that kind of felt like they fit a similar theme, but basically individuals that are higher risk for sleep apnea, probably be reasonable to test them in an attempt to better understand what's going on and hopefully influence the outcome in a way that gives them a better recovery and shorter symptoms and less impairment. So this is something you could just return to if you need to reference it later, but big picture, we're just going to talk about TBI first, then we're going to review obstructive sleep apnea, kind of discuss the relationships and overlap, and then talk about screening and testing. So I put the Montana Utilization and Treatment Guideline definition for mTBI or mild TBI in the top left. It doesn't read real smoothly. The way I'd like to summarize it is a concussion or mild traumatic brain injury is characterized by a head injury, which may result in brief loss of consciousness of 30 minutes or less. There's a lot of criteria they're trying to include in there. And so I understand why it's written. I kind of pulled out the salient points, but there's on the right, you can see a graph that it gets used pretty regularly with concussions and head injuries that is kind of a hypothetical recovery path. So it's just kind of what you'd expect on average. You've got your pre-injury function. Can you guys see I don't know if you can see my arrow or not. It doesn't look like it, but then you have the incident or the injury. You've kind of got that immediate deficit noted, and then gradual varying degrees of recovery as they get as time goes by. And so with mild TBI, generally a quicker recovery and less persistent symptoms, whereas moderate and severe things continue to gradually improve on average. And I'm sure you guys have on average heard that concussion is another term for TBI, or mild TBI in particular. I would say that generally it is a better term to use. It just avoids over medicalizing the injury. People generally think of concussions as something that's short term and tends to improve and resolve, where sometimes traumatic brain injury has pretty scary connotations, especially in the moderate and severe and blast injuries and stuff like that. So on average, I'd say if you can use concussion instead of TBI with mild TBI patients, I think it would probably be more appropriate. Post-concussion symptoms are not maximal at the moment of impact. They do kind of build for the first few days as neuroinflammation and healing cascade starts, generally starting to improve within a week and recovering 2 to 4 weeks out. So my analogy there is like similar to a sprained ankle. I mean, you know it happened, you have a lot of pain initially, but maybe that person works in their work boot for the rest of the day before they take their boot off, and all sorts of swelling and bruising happens for several days. And, you know, obviously the analogy starts to break down if you really go into the details. But the point is some of the neurocognitive symptoms in particular, some of the dizziness and sleep issues, those are going to happen several days to even a couple weeks out, but they shouldn't really be showing up months out. And then we've got this caveat of the TBI people that have just slow recovery, 10 to 20% on average. Post-concussive symptoms or syndrome gets used as well, but basically persistent physical, cognitive, and emotional sleep symptoms. And then the leading cause of work-related TBIs, motor vehicle accidents, falls, getting struck by an object or against an object, and in certain work environments, assault potentially. It's not all inclusive, but a vast majority of what we're seeing. I was surprised at how many of the ones I reviewed were motor vehicle accidents. I mean, I knew that was a common one, but it felt like that was almost all of them. There's just another way to look at the severity of TBIs. It's a busy slide, but mainly here to just reference that TBI exists on a spectrum from mild to severe. Mild being a brief disruption of normal brain function, such as confusion, disorientation, or short loss of consciousness caused by trauma in the absence of structural brain injury on standard neuroimaging. So again, we'll focus mainly on the mild TBIs, but some of these concepts, and especially a lot of the studies about neurocognitive impact in traumatic brain injuries and the sleep obstructive sleep apnea overlap, have a lot of moderate and severe TBIs in their study population. So it can be really challenging to tease out mild TBI and OSA overlap alone. Oops. So common neurocognitive symptoms after a mild TBI or concussion, not an all-inclusive list of symptoms, but included to begin to kind of highlight the similarities and overlap with sleep apnea. So all the ones with the little asterisks are things that you could potentially see in someone who hasn't had a TBI, but just has untreated obstructive sleep apnea. Things like attention, concentration, processing speed, memory, word finding, executive function, headaches, fatigue, sleep disturbance, and then mood stuff like anxiety, depression, irritability, feeling foggy or removed, detached. So this is all essentially from the Montana Utilization and Treatment Guidelines for mild TBI in regards to timeline and delayed recovery. So again, concussions generally do not get worse after the first several days. And so a lot of the insights on the injury itself and the prognosis for how things should go are generally in the medical notes from that first week or so. 75 to 90% of individuals will recover within 90 days. But again, there are situations where we have these persistent symptoms 6 to 12 weeks out, a couple months, 3 months, 6 months even. And at that point is really when we should start, if it hasn't been done already, start honing in on what else might be going on. So issues such as psychosocial, sleep disturbance, pain, other medical issues should all be considered essentially as soon as there's any red flags, but certainly a few weeks or a few months out from the injury if they're getting worse or not getting better. From the treatment guidelines, individuals who have not improved by 6 weeks post-injury should have a full neuropsych eval. And then just kind of starred what I think is relatively a big point at this stage is there's essentially 2 opportunities to identify sleep disturbance at this stage and neurocognitive symptoms. So you can certainly the treating provider should be paying attention to that kind of thing and using instruments that we'll talk about, such as the Epworth Sleep Scale and Stop Bang. There's a few others listed in the utilization and treatment guidelines. So they should certainly be trying to identify it by this stage. And then again, neuropsych eval should be considered around the stage 2 in the delayed recovery setting. And they generally will screen for it and catch it as well. So again, from the utilization and treatment guidelines, specifically referencing sleep disturbance in concussions, it's frequent, can have a significant impact on functional recovery. It can exacerbate secondary symptoms such as pain, headaches, and mood disturbance. It is verbatim in there that OSA can develop in up to 35% of individuals after TBI and should be identified and effectively treated. My note in orange just saying, of course, we can have OSA that is pre-existing or OSA that was maybe subclinical or undiagnosed but worsening after the TBI. And the reason we want to catch all this, obviously unaddressed sleep apnea can delay recovery, delay return to work, inflate the disability duration, lead to a wide variety of medical problems and neurocognitive psych problems for the individual. So again, OSA should be identified and effectively treated if present. Polysomnogram or PSG is appropriate when an underlying sleep disorder is suspected. And it mentions also that sleep disorders should be ruled out when appropriate symptoms are present before proceeding with other sleep treatments. So essentially, you want to know what you're treating before you start getting too carried away with treating. And so that's where some of the screening and potential referral will come into play. So now I'm on to sleep apnea, defining it, risk factors, prevalence, etiology, pathophysiology. So another few busier slides coming up, but intended to hopefully be a reference, just a lot of detail to sleep apnea. So the basic concept with sleep apnea is chronic, frequent episodes of impaired breathing while asleep, resulting in a wide variety of medical and neurocognitive problems, generally worsening over time if not treated. The specific definition is a sleep-related breathing disorder characterized by complete cessation of airflow, known as apneas, or partial reduction in airflow, known as hypopneas, lasting at least 10 seconds during sleep. That's generally found definitively on the sleep studies, but it disrupts oxygen to the brain and body, known as hypoxemia, or hypoxia is another term. Hypoxemia would be low oxygen in the blood, and hypoxia is just kind of a general term for low oxygen, but also sleep fragmentation and sympathetic surges, which hormones, the pituitary, all the kind of stress hormones of the body, while you're essentially suffocating at night and not realizing it, are kind of going haywire. And we'll get into that. So there's three main types of sleep apnea. There's the obstructive sleep apnea, which is most common, and that's dealing more with a airflow issue, so repetitive narrowing or closure of the upper airway during sleep, despite respiratory effort. So these people are trying to breathe. Their chest wall is expanding. Their diaphragm is essentially trying to pull air in, but it's because of the closure and narrowing in the airway, they're not having any respirations or minimal, interrupted for sure. And then there's also central sleep apnea, which is more of a decreased respiratory drive signal from the brain. And so in those cases, there generally is no respiratory effort. And there are 6 subtypes of central sleep apnea. So we won't get into all those, but it is more common early on in some TBIs, especially moderate and severe. But there's a lot of nuance to TBIs and to the individual that they occur to and their risk factors and stuff. So you certainly could see central sleep apnea as a result of a TBI. It's also more common in patients with underlying cardiac and neurologic conditions and chronic opioid use to suppressing the respiratory drive. And then there's also a mixed sleep apnea. So many patients exhibit features of both central and obstructive due to unique aspects of their pre-existing risk factors and health problems, as well as potentially their head injury. And again, polysomnography or PSG, gold standard for diagnosing and differentiating the types of sleep apnea. So this is basically risk factors and symptoms for obstructive sleep apnea. You got the risk factors on the left in darker blue and the symptoms on the right in orange. The bold and underlined are some of the most classic and common. And I specifically want to point those out because they're included in one of the validated screening tools known as Stop Bang, which we'll get into what that is here in a bit. But generally, you're dealing with people who are obese, big necks. It's more common in men and older people. Generally, especially if it's been going on for a while, they're going to have high blood pressure that isn't responding well to medications, or maybe isn't treated. And then kind of some of the classic symptoms are snoring, apneas, gasping, and choking during sleep. A lot of times people don't know they do this, especially if they don't have a bed partner or spouse telling them. And so it generally helps to have a witness of some sort who can kind of vouch for whether or not that's happening. Excessive daytime sleepiness is kind of one of the main hallmark symptoms as well, because essentially these people aren't really getting well rested, even though they feel like they sleep well all night or they sleep like a log or something like that. A lot of people have kind of a colloquial view of sleep apnea. They think it's more insomnia. So they'll say, I sleep fine, or I sleep like a rock, or I could sleep, at the drop of a hat. And that's actually how sleep apnea generally is going to work for people, because they're so exhausted from not really having restorative sleep that they can sleep really long and they think they're sleeping well, but they're having these episodes throughout the night. And so they're going to have the excessive daytime sleepiness and fatigue. And in the context of work in particular, it's worth mentioning they're going to have elevated occupational accident risk, as well as elevated chances of motor vehicle accident due to the fatigue and some of the neurocognitive impairments that come with not being well rested, which we'll get into here shortly. So prevalence is kind of all over the map, but I found a study that's pretty new that estimates that it's essentially a third of US adults over the age of 20 have at least mild OSA. My analogy would be similar to, say, like autism, where they used to think the rates were really small, and whether there's actually more of it than we realized, or we're getting better at diagnosing it, or the risk factors are increasing. It's kind of one of those pictures. So a lot of these studies have kind of been snapshots in time, but over the years, the prevalence just keeps increasing. And so this newer study here suggests that roughly 26% of females and 39% of males in the US have at least mild obstructive sleep apnea. And we'll get into what stages the different severities, but it's estimated of those people that are the 84 million, or 1/3 of the adult population, roughly 50% are mild, 30% are moderate, 18% severe. The prevalence is tied closely to rising obesity rates. It increases substantially with age as well, due to increasing risk factors and decreased muscle tone. Men on average are about 1.5 to 2 times more likely in the premenopausal stage for women, but then women start to catch up as they postmenopause. And it's estimated that a large portion are actually undiagnosed. So there's a lot of people out there that have it that don't realize it. So this was a prevalence graph that I had Claude AI put together for me, but basically just showing that throughout, as people age, they're going to have higher rates of, or higher prevalence of, obstructive sleep apnea. And you can see the men are blue, the women are pink, and as people get older, those rates start to get closer and closer, and the rates are obviously getting higher for both groups as you age. And so the reason, again, is generally decreased muscle tone, increased adipose or fat, and obesity kind of driving the trends as well. So now let's talk about neurocognitive impairment and some of the other health problems related to untreated OSA. So we'll start with neurocognitive impairment, as it introduces two of the main drivers creating chronic complications in obstructive sleep apnea. On the left in orange, you've got chronic intermittent hypoxia, or hypercapnia, which is essentially lower oxygen and higher carbon dioxide in the blood and brain. And then on the right in the turquoise is sleep fragmentation. So because they're essentially suffocating throughout sleep, they're going to have recurrent arousals where they go to lighter stages of sleep, and thus they're having less restorative sleep, such as the slow wave and REM sleep. And the impact on brain regions, it's pretty complex. So we'll just kind of stick to the high points. But basically with the hypoxia, or the lower oxygen in the blood and brain, you're going to have oxidative stress, cells are being damaged, and there's inflammation present. And so short term, this symptoms like headaches. So a lot of people with OSA might have a morning headache that goes away throughout the day as they start to ventilate normally. But long term, it can create brain changes of atrophy and small vessel disease that's visible on imaging. And then with the sleep fragmentation, those recurrent arousals can also lead to brain changes, reduced plasticity and neurogenesis, basically changes in the gray matter over time that they can see on imaging. So how all that translates to cognitive domains, there's kind of a wide array of symptoms that can happen because of those changes, but your biggest ones are attention and vigilance. So deficits with reaction time and attention lapses, they'll end up having what's called micro sleeps, but that leads to motor vehicle accidents and occupational risk. The executive function is kind of the all things really, but impacts cognitive abilities, difficulty making decisions, multitasking, planning, organizing, and then memory as well. So may have trouble remembering what the doctor just told them about their new meds, or you know, what they were going to get at the grocery store or whatever. But and then mood and behavior too. So generally they're going to have more symptoms of depression, anxiety, fatigue, irritability, that kind of thing. This slide also looks very busy, but just focus on the red boxes. So on the left red, this is the pathophysiology of untreated OSA. So these are a couple of things we already talked about: the intermittent hypoxemia or hypoxia, so lower oxygen in the blood and brain, and the sleep fragmentation. Then you also have these large intrathoracic pressure swings. And so what's going on there is basically during normal breathing, the chest and the diaphragm are trying to bring air in. You do it, subconsciously. When you breathe, your diaphragm is bringing air into your lungs. But when you have a restriction or an obstruction, the airway is collapsed. That blocks the airflow, but the breathing muscles don't necessarily know this. So they keep trying harder and harder to pull air through the airway. And this is essentially like trying to suck a milkshake through a pinch straw, for example. So the more you apply suction, the more the straw kind of collapses, more negative pressure. And so basically what that is, it's like sucking blood into the heart, because the heart is in the chest as well, of course. And so with each failed breathing effort, you're creating a large negative pressure vacuum. And this acts like a suction force on the heart, pulling blood in from the body faster than normal, overstretching the heart's chambers, forcing the left ventricle to work much harder to pump out blood against that pressure. And then over time, that creates mechanical stress and strain on the heart. It stretches the atria, increasing the likelihood of AFib, contributes to left ventricular dysfunction, elevated blood pressure, heart failure. So the red box on the right is kind of when these kind of cascade of pathophysiologic complications from untreated OSA result in disease endpoints. You're seeing kind of some of the more common and catastrophic health problems that can result just from untreated sleep apnea. And so the little red arrow is just kind of breaking that down a little bit more, but you can have cardiovascular, metabolic, neurocognitive, which we're spending some time talking about, pulmonary, endocrine, and then perioperative risk was another one that's mentioned. So when someone has untreated OSA and they go to have a surgery, anesthesia medications can compound the OSA and create major patient safety concerns with that surgery. And so I think most of this you could probably just reference back, but it's essentially just showing that it isn't just like a breathing and oxygenation problem on its own. It's just this cascade of significant health problems that cause all sorts of problems down the line if it's not treated. All right, so talking about the overlaps between OSA and TBI in terms of neurocognitive symptoms. So cognitive presentation can be strikingly similar and often co-occur. So on the left, again, we've got the sleep fragmentation and hypoxia with obstructive sleep apnea. And then on the right, we've got the acute brain injury and neuroinflammation from the concussion. And then these are, again, symptoms or presentations that are very common for both and that can feed back on each other and kind of compound the situation. So all the stuff we've already talked about. And this gets to the importance of trying to identify OSA as it is treatable. And when it's untreated, it impedes TBI recovery and confounds symptoms that were initially attributed to the TBI. So kind of what came first, the chicken or the egg thing here? Is TBI causing or worsening OSA, or did the OSA already exist? It is generally considered a bidirectional relationship. So untreated OSA increases the likelihood of a TBI. We've kind of hinted at that a little bit, but again, chronic intermittent hypoxia, sleep fragmentation that leads to that neurocognitive impairment. And that neurocognitive impairment leads to delayed hazard recognition, impaired response, microsleeps. So this is doubling the odds of workplace accidents. It's a significant contributor to motor vehicle crashes. And that's why it's screened and emphasized very thoroughly in like Department of Transportation exams and FAA physicals and that kind of thing, is trying to catch this stuff so you can hopefully minimize catastrophic accidents. There's a lot of evidence that suggests that TBI causes or worsens OSA as well. So after the TBI or the concussion, untreated OSA can mimic, magnify, and prolong post-concussive symptoms. TBI can disrupt the brain respiratory centers. It can impact the respiratory drive. It can change the muscle tone and inflammation and swelling of the airway. And it can lead to obstructive central and mixed apneas. Then you've also got to factor in medications. So opioids suppress the respiratory drive. And that's true for alcohol too, and other sedatives. And they can decrease muscle tone as well. And then, oftentimes we're prescribing muscle relaxants for people with like neck strains or like sometimes benzodiazepines are used in like the psych component. And so all those can have an impact on the respiratory drive and the muscle tone and inadvertently be contributing or worsening symptoms of OSA or severity of OSA. And then in longer term injury where people maybe have weight gain, reduced activity, maybe they've been not necessarily with a mild TBI, but maybe they've been hospitalized with more severe TBI, but just some of that sequelae of significant head injury can lead to metabolic changes and increase OSA in post-TBI patients. And again, that's generally shouldn't be happening quite as much with mild TBI as moderate and severe, but just so many of these studies really can't tease out. Most of the studies are conducted in like trauma centers and neuro rehab facilities. And so they have overrepresentation of, symptomatic people with significant head trauma. And generally we don't have pre-injury sleep data on these people. And so it makes it hard to confirm whether OSA was caused or worsened by the TBI or if it was pre-existing. And hinted on this a little bit earlier, but central apneas do increase acutely post-TBI on average. They may evolve to obstructive over months. And then there's that complex or mixed apnea, which is also common in TBIs. And again, oftentimes kind of more of the moderate and severe, but hard to tease out the mild from the studies. So next slide here. So when they co-occur, it is a common and under-recognized clinical scenario. Evidence suggests this bidirectional relationship where each can cause the other and both share common symptoms. And so again, that's what really kind of drives home the point of we don't want to be missing or ignoring OSA if it's there. Again, many studies suggest higher rates of sleep disturbance and OSA in TBI patients, though the attributable risk of TBI leading to OSA is difficult to generalize due to so many variables from case to case and the methodology limitations across the studies. Conversely, a TBI may be the clinical event that reveals previously undiagnosed OSA. So as we know, a lot of these workers maybe don't have primary care, aren't seeing them regularly. No one's really paying attention to whether or not they have risk factors for OSA. So that's why I think it's reasonable to at least have that on our radar in these situations where we have persistent neurocognitive deficits and delayed recovery, because it's certainly a strong possibility that they have some degree of sleep apnea. So the consensus is that early diagnosis and treatment of coexisting obstructive sleep apnea in the TBI population will generally result in improved outcomes and help to minimize long-term cognitive impairment. All right,
Devin,
so on to,
it's 12:40.
okay, great. I think we're doing all right. I'm gonna take a quick sip of water here.
And everybody will leave about 10 minutes at the end for questions as well.
So screening, testing, diagnosis, who to screen and when. You know, at this point, we've kind of hit on a lot of this, but basically, we want to be screening people who have delayed recovery, persistent neurocognitive symptoms, and risk factors for OSA. And so that's kind of what everything on the left with the orange bar says. Um, and then on the right is some of the more common validated screening tools that are pretty user friendly and straightforward. I was going to talk specifically about the Epworth Sleep Scale and the Stop Bang questionnaire. Those are the ones I'm most familiar with, and they're kind of the most straightforward as well, just easier to present on. The Pittsburgh Sleep Quality Index and the Berlin questionnaire are also really helpful. They're just a little more nuanced and don't really lend themselves well to a quick rundown of what they are. So those are worth acquainting yourself with. And so the Epworth Sleep Scale and the Pittsburgh Sleep Quality Index are more geared towards sleep quality generally. And then the Stop Bang and the Berlin questionnaire are more OSA specific. But these are all screening tools to help decide if further testing would be warranted. So the Epworth Sleepiness Scale is done when you have concerns about excessive daytime sleepiness. Again, that's kind of one of the hallmark symptoms of obstructive sleep apnea. And it's this thing on the right here in green. And it's basically just how sleepy are you? How likely are you to fall asleep doing these different activities? So um, it's one of the earliest tools used to screen for sleepiness. It's been used in DOT physicals and commercial driving for a long time to kind of screen for OSA. If the patient is being honest, it can be insightful. A lot of times people don't quite understand, even though it's a pretty simple set of questions, people who probably don't have OSA are just convinced they're so tired all the time. And then maybe people who probably do don't really quite recognize just how tired they are. But I'd say on average, it's a decent place to start if they are complaining of daytime sleepiness. And so real world consequences, of course, we're trying to find that underlying sleep disorder such as OSA. It also suggests they'd probably be at higher risk for motor vehicle crashes, workplace injuries, near miss events, and absentee presenteeism are also affected by excessive daytime sleepiness. The Stop Bang, I think this is probably the best one in my opinion because it's just really straightforward, but Stop Bang being an acronym for symptoms of snoring, tiredness, observed apnea, and elevated blood pressure. And then Bang being more demographic type stuff. So their obesity, age, their neck circumference, and their gender. Um, so just even from reviewing the individual's medical record, you can get probably enough data to answer this. You may not know necessarily about their snoring or tiredness or observed apneas, but a lot of these people clearly have high blood pressure, clearly obese, probably over 50, probably a male. So they're already getting close to that high risk level. Neck measurement, sometimes people know that, but a lot of times it's just better to integrate it into your exam with like a paper measuring tape or a soft measuring tape. Sometimes they'll know their neck size for their shirt, but a lot of times, especially once you've done this for a little while, you can just tell by looking at them because 16 inches isn't really that big. And so certainly if they're obese, they're going to have a neck bigger than 16 inches. And then if they don't necessarily know about their snoring or apneas, again, it's helpful to ask a roommate or a spouse or someone who can speak to that. Sorry, it seems like it's stuck again. Okay. So another slide that's probably just better to reference later on if you need to, but it's just trying to compare the differences between polysomnography or polysomnogram, PSG, which is generally considered the gold standard, to what's probably more common for the average person that might have sleep apnea, but I'd say generally in TBI populations and situations where there's this neurocognitive component where you're trying to tease it out. A lot of evidence suggests that the home sleep apnea test isn't going to be that helpful because a negative one, but yet with high probability, they're probably still going to need the polysomnogram. And, you know, a lot of times we're getting these people to sleep clinics, and so they're making that call. But I would say in general, even though they're going to be maybe more expensive, there's just so much more detail from the PSG that can help kind of flesh out what's going on. So just read a little paragraph here in my notes section, but a home sleep test is a limited device. It cannot measure brain activity, confirm the patient was actually asleep, or detect other sleep disorders that commonly occur after brain injury. Because it cannot confirm actual sleep time, the home test routinely underestimates sleep apnea severity in brain injury patients who frequently have difficulty sleeping, thus producing a falsely low or even normal result. PSG, however, is conducted under continuous supervision by a trained technologist who monitors the patient all night, verifies sensor placement, and corrects problems in real time, producing a complete, verified, and tamper-evident record that an unattended home test simply cannot provide. The American Academy of Sleep Medicine specifically recommends in-laboratory PSG over home testing when a patient has neurological conditions, additional suspected sleep disorders, or when the integrity of the test must be fully documented, all of which apply directly to work comp claims with TBI. And this is essentially the same thing, but in a paragraph format that people can read on their own. But I would say that the two things I want to emphasize are probably the last two bullets in orange, which chain of custody records in polysomnogram provide validated tamper-evident data for medical, legal, and IME context, and that the American Academy of Sleep Medicine says that polysomnogram is preferred when home sleep apnea test is technically inadequate or clinically inappropriate, which clinically inappropriate essentially being symptomatic TBI patients, you know, potentially on meds, possible secondary gain, that kind of thing. So, and the other thing, and we already mentioned it, but basically there's a lot of brain injuries in TBI that can result in other types of sleep disturbances that aren't necessarily sleep apnea that a PSG can detect, whereas a home sleep test can't. And that's kind of what the top box is talking about. So you get your sleep study done, and these are just kind of how the results are generally communicated. The severity is determined by the apnea-hypopnea index, and kind of breaks it down there in terms of mild, moderate, severe. The sleep medicine providers are generally going to go into the weeds as to what all this means. I don't think we necessarily need to spend a lot of time on it, but just knowing again that it exists on a spectrum, and so their symptoms and their treatments can vary. And so when do we treat? Generally, if they're mild but are having symptoms, they'll generally warrant some degree of treatment. And so this isn't necessarily specific to TBI, but just in general. And then if they're more moderate or severe, then even if they don't have symptoms, generally treatment's recommended. And so similar to something like, say, obesity, where you could have someone who's obese, but they're actually pretty healthy in the sense that their blood pressure is normal and their cholesterol is normal. Or you could have someone who's maybe not obese, but they have higher risk factors, or that's kind of what's going on here too. So you can have people who have significant AHIs, but are essentially asymptomatic. And so that's again where the the sleep medicine specialist helps kind of tease out the results of the polysomnogram to decide how to interpret it all. All right, and then just a little bit on treatment. Certainly because a lot of this is driven by excess weight, weight loss can be helpful. We know how hard that can be in a lot of situations. And so that's where PAP therapy is generally considered first-line treatment. And then there's a few other ones that I mentioned in here and we've probably heard of, but devices that kind of change how your mouth is opened and positioned that helps kind of open the airway a little bit more. Those can be appropriate in certain circumstances. There's surgical and stimulation type devices that can help with OSA. There's what's Zepbound, I believe, is the GLP-1 that is FDA approved for obesity-related sleep apnea. And then it'd be pretty rare that they'd be on a stimulant medication for residual daytime sleepiness, but that would again be kind of determined by the sleep specialist. So a little more on PAP. I think historically it's always been called CPAP. A lot of it now is actually APAP. So CPAP just means it's continuous pressure. It's kind of a fixed pressure all night, but that makes it harder to blow out. So you get like a lot of mask leaking when they're on CPAP. AutoPAP actually senses the amount of pressure that needs to be there to provide that air pressure that basically creates, they call it a pneumatic splint, but basically it keeps the airway open. So the AutoPAP is kind of where things are headed. And I think that's what most people get these days. And then there's certain circumstances where like a BiPAP would be more appropriate, but there are benefits from adherent use, and that's essentially kind of decreasing or reversing a lot of the symptoms that we've talked about. The neurocognitive symptoms do tend to improve. The blood pressure tends to improve. Their daytime sleepiness tends to improve. Obviously, it's kind of a case-by-case basis, and it has a lot to do with how well, how adherent they are to using it. And some of the, if it's been long-standing chronic sleep apnea, some of the structural brain changes and the symptoms to go along with that, may not reverse or be slow to improve. So in summary, I made this slide just to talk about everyone that's generally involved in the care team. Oops. And that's something to reference later, but basically everyone should be kind of keeping an eye out for this, so it isn't at the very end in the IME where someone's like, hey, did anyone think of sleep apnea? I think we have a lot of work comp case managers on the call, so just keeping an eye out for those risk factors, considering trying to help coordinate the screening. Some of these cases might warrant a nurse case manager to help kind of direct care. And ideally, the treating provider, the treating physician, is keeping up with this throughout the course of the recovery, so they're catching it early on with some of these screening instruments. But again, the key point, OSA is very common, particularly with TBI. And if we can catch it and treat it, then we can feel confident that what symptoms persist are maybe more attributable to the TBI as opposed to untreated OSA. And if everyone's kind of tuned into it, then we can hopefully avoid that concept of like the Swiss cheese model where the condition passes through everyone and no one catches it. So these are high risk situations where really should be caught and sent for sleep study, but basically the safety sensitive jobs, the disproportionate TBI symptoms when there's risk factors for OSA. At the end, if it's towards MMI, if OSA hasn't been caught, it'd generally be something to address, because then you're potentially given an impairment rating for something that's reversible. And then, sometimes people have gained a lot of weight or had studies in the past, and it's easy to dismiss as, oh, they don't have sleep apnea, but it might be worth retesting them. And then the classic symptoms of heavy snoring apnea is gasping, choking. That pretty much implies some degree of sleep apnea. I think this is the last slide. So it's all stuff we've already talked about, and I'll just leave it up there. And if anyone has any questions, I'm happy to answer them.